Hey, we're excited to be partnering with UnityPoint-Health St. Luke's on this presentation, this virtual first year experiential activity in regards to healthcare. This is going to be an incredible opportunity for you not only to learn a little bit about UnityPoint Health, but also hear from a panel of experts about a healthcare case, and then finally also learn about some volunteer opportunities as well as perhaps part-time jobs for you to get engaged with the hospital to learn more about what you might want to do in the future, whether that's job shadowing, like I said, volunteer or part-time jobs, or ultimately employment following graduation. But that all starts with the conversations that we're able to have right here and meeting some of these individuals. And so just some of the ground rules that I want to remind you of today is, I would say, first and foremost, if you haven't dropped your first and last name in the chat, please go ahead and do so. While you're thinking about that in the chat as well, throughout the presentation, we're going to showcase a video that will actually tell you a little bit about UnityPoint Health and kind of what their employees and actual Morningside alumni think of the organization and how it's impacted their lives. But also, we want you to be able to take that chance during the presentation and the panel to be able to ask questions, to engage with the panelists and ask questions or be able to answer things that they would maybe ask of you. So really utilize that chat function. Otherwise, we want you to keep muted at all point in times. If you have anything, drop it in the chat. At the very end, we might have some questions or some time for questions where you'll be able to unmute yourself and ask that question. Another thing that I would just remind you is that if you can go up to the top right of your screen, and I would really recommend selecting active speaker with thumbnail video view. Active speaker with thumbnail video view. That way you make sure that you're not actually on grid view, because I think with active speaker view, you're really going to get the full experience where you will have your full screen looking at the panel and those individuals that are going to be leading us in this discussion today. So with that, I want to go ahead and I want to be able to start this video showcasing the culture and individuals that are at UnityPoint Health. And what I loved about it is they showcase some Morningside students and alumni. And so that's great as well. Let's get to that video.
Being an HR business partner means partnering with my leaders and the departments I support, working with them, whether it's on hiring or staffing issues or employee engagement within the department, and supporting them through all of those processes.
Even though I don't work bedside nursing anymore, I have helped with the rollout of the COVID education to the staff, what COVID is, so that the staff can understand it, to know what kind of proper PPE to use, all the different processes here at the hospital that we've kind of implemented due to COVID.
So when the pandemic hit, I was told that I'd be on the dedicated unit for probably 95% of my shifts. As a nurse, that was a little intimidating and made me nervous, but you know, it's something we have to do when we sign on to be a nurse, because we really didn't get to see a whole lot of other staff during the day or visitors, like I said. So it was really important for us to stay in contact with these patient and family members. We got iPads to Zoom call the patient's family. You know, they couldn't see each other, so whether it was bringing those family members into those patients' rooms or Zoom calling these other family members to get them to see them. And you know, some of them passed away, some of them didn't, and it was really important for us to be that kind of middleman to help these patients see their family members during this time.
Learning just like what we all have to do and what the precautions we're taking to try to stop the spread, flatten the curve as much as we possibly can, while also doing our best to help each and every patient that's in this hospital.
Unity means to me a team. It's all about teamwork here. We have a great team of physicians, nurses, staff that work together to have the best outcome for that patient.
Unity to me means teamwork, and obviously throughout the pandemic or not with the pandemic, it's extremely a vital part of being a nurse, because you rely on your other nurse coworkers, your techs, lab, housekeeping, everyone kind of works together.
To me, unity means family. We are all working towards one goal. We each play a part in that, but as a family, we work together to meet those goals.
Unity means to me family, and this atmosphere in this hospital specifically, in this workplace, this whatever area you're in, makes every person feel like they're a family member, that they're well cared for, that they matter, and that we will do anything and everything that we possibly can to help make their experience here, as difficult as it may be for them, the best experience that they can have.
Excellent. I think that video does a great job capturing the culture of UnityPoint Health and kind of the transition that they've went through. Now to speak to a specific case and actually introduce the panel that we have with us today is going to be Taffy. Taffy, go ahead and take it away and introduce who you got with us today.
Thank you so much for visiting and being part of our healthcare team today. I am going to be actually turning it over to Lacey Fries. She will be doing our PowerPoint presentation to highlight a patient story through our COVID pandemic. And as we go through the case study, we will then introduce our panel, and each one of our team members will be able to tell you a little bit about themselves and their role during the pandemic. Thank you.
Well, good afternoon, everyone. I'm Lacey Fries. I'm a nurse here at UnityPoint. I'm on the critical care team, so I work in ER, ICU, and some cath lab. I'm also the ICU educator and the sexual assault nurse examiner program coordinator, so forensic rape kits, if you will. Prior to being a nurse, I taught English for 7 years. I've done many different things, and this is where my heart is at. I hope during this presentation today we'll kind of plant that seed in many of your hearts and minds that there's a place for all of you in healthcare, whether it's pharmacy, x-ray, chaplaincy, something. It's a very varied field, and at the end of the day, you put your head down on a pillow and feel really good about what you did for your day. So moving on to our case study, the big focus, obviously, it's 2020, is COVID. To give you guys a little background, when we had our surge in the spring. Louder, a little bit louder. To give you a little bit of background, when we had our surge in the spring, our facility has an 18-bed ICU. Within a matter of days, it went to 43 patients. 10 were clean ICU, meaning non-COVID, that were housed in another unit. And 33 of those patients were very, very ill COVID ICU level patients. Doubled up in rooms, just like you saw on the news, those surges. I would like to tell you ahead of time something about UnityPoint St. Luke's that's a stellar statistic. We recently had a study that was published for acutely ill ICU level COVID patients. The national mortality rate is between 39 and 50%, and St. Luke's was 12%. That is, that's one of the lowest in the entire country. So we're doing a really good job here, and that wasn't a one-person thing. There were very, very many people in this hospital that contributed to that. So let's move on to our case study. Okay, so we have a 50-year-old male, Spanish-speaking only, works at a local meatpacking factory. Why that's pertinent is they're working in very close proximity with each other. With a language barrier, they may not be hearing the prescriptions on TV or local health of when they should stay home, temperature taking, things like that. He also lives in a multi-generational household. Why that's also pertinent is little kids are really good spreaders, but they don't get very sick with COVID. Old people are very vulnerable. And then you've got your big workforce from 20 to 60 on average that's out there, and it needs to bring home the bacon, if you will. They don't want to report that they're sick and want to keep going because of that. Next slide, please. So this gentleman presents to the emergency department here at St. Luke's. He's had shortness of breath for 4 days before coming to the emergency department. This is the real big one, folks. Oxygen saturation is 43% on room air. I'm going to explain to you why that's extreme. You're sitting in your dorm or classroom or a library right now, and the normal air that you're breathing, that we call room air, is about 21% oxygen. In the mountains, a little bit thinner. So on that 21% oxygen, you or I should have a blood oxygen level of about 98 to 100% would be normal. So he walked in room air, and his saturation was 43%. Usually when it's that low, somebody is dead. This is extreme. So his nasopharyngeal COVID test came back positive. Nasopharyngeal is that one you've heard about where they go tickle your brain up your nose, both sides. It's not fun. So he becomes an inpatient because of this and other labs that qualified him. He goes to a dedicated intensive care unit. What dedicated means is that ICU unit is closed off to everybody. Doctors did not come in there. They used telehealth via computers to evaluate their patients. Lab did not come in there. The nurses grabbed all of the blood work and ran it to the line. Housekeeping did not come in there. We cleaned and ran the garbage to the line. All of your ancillary and helping hands departments were not in there, except for radiology. They would come in and do our chest x-rays and such and garb up in the PPE. The reason that this was implemented, if you remember from the news, is we had an extreme shortage of PPE, and that's your personal protective equipment, such as masks, gowns, gloves, such. So we were really trying to make that supply last.
Pass this one too.
I just wanted to show you guys, this is a picture of that nasopharyngeal test. So that's how far back they go. No, it doesn't go straight back and poke right through your nostril. It goes up and then kind of down when you meet resistance. Next slide, please. So you guys being non-radiological people, when you look at this at first glance, you're not going to know everything that you're seeing. But it's so extreme. If you were to look at the left versus the right, it looks pretty cloudy and unclear, right? Well, we have tiny little alveolar sacs, they're called, in our lungs. Those are little sacs that we absorb air through, and it goes into our blood and gives us that oxygen we need. Those air sacs got really jumped up with swelling, mucus, the normal things that the body responds to illness with. So we have a lot less good space to breathe in that air that we need. So that's why these people are satting or have a blood oxygen saturation that's very low, shortness of breath, really altered level of consciousness because of this, and then there's a cascade of other things. And then on the right, it's much clearer. Advance slide, please. This is just a picture of a dedicated unit where everybody's in their suits. It looks extreme if you've ever seen the movie Outbreak or any kind of science fiction film, but it's real. That's what we wear, and that's to protect them, protect you, protect us, and try to help limit the spread in our community. Advance slide. So, high flow oxygen. If you remember previously, I had said the room air that you're breathing right now is 21%. These people were put on oxygen that was 100%. The liters that we breathe in a minute of air, they were put at 60, 70, or flushed out to 90 liters a minute of this 100% oxygen. They were then proned. Proning is when you lay on your stomach. The reason is that expands that lung so that you can try to optimize any of the sacs that are left to try to get that air. BiPAP, I'm not sure if you can see via video, is a pretty extreme face mask. The bi meaning two. So it's biphasic. It's going to shove air in and out. It's the step that comes before someone being on a ventilator. So if someone does have to be on a ventilator, first we're going to have to stick a tube down their trachea, otherwise known as their windpipe. So we're going to intubate, it's called, put this tube down their windpipe, and then to get it to stay so it doesn't come undone or we're putting air in the wrong place then, I've got a little syringe here, and I'm going to blow it up with air. There's a little balloon here. And I don't know if you guys can tell from there, but this blows up and sits down there so that it doesn't become dislodged. This is then hooked up to a machine that breathes for that patient, okay? So because of that, then the patient has to become sedated so they don't fight the ventilator. So big drugs, big air, a lot of big interventions happening. Another big thing that's happening when you see frequent skin checks, you or I, how many have been sick at home for a day or two, and what hurts the worst when you're done? Your back from laying there that long. All we want is a break in life. We finally get sick for a day and we're like, never mind, that hurts. Well, these people were intubated in the ICU for 4, 5, 6 weeks. So imagine being on your stomach or your back. We have to turn them frequently. The disease and the drugs that they have and are on are breaking that skin down. Your skin is one of your organs, biology majors, and it is also our first line of defense when you're speaking about your immune system. So it's very, very important. Frequent vital signs, of course. This changes depending upon what department you're in. In the ICU, it's not uncommon at all where every 15 minutes those vitals are being taken because they are changing that fast. and we have to adjust the drugs that they're on that fast, and sometimes even more frequent than that. And then they have a lot of IV medications. So anybody that maybe has been sick or had the flu or been dehydrated, and you go in and you get an IV and a bag of food to get you hydrated, imagine that times 10 or more. Oftentimes they will have what's called a central line placed in their body. What that is it's a big IV right here in their chest or their neck, sometimes a smaller one in their arm right here. That way we can give multiple IV medications at the same time that they need, or blood products, anything that's keeping them alive. So most of these people, when they're in the ICU, they've got a ventilator keeping them alive with their breathing. They've got drips, as in medication drips going through their IVs, keeping their heart and circulatory system alive. Tons of antibiotics fighting it. Plasma from other people that have had COVID and have the antibodies to help them boost their immune system. They would not be living on their own if they weren't currently getting those things in the ICU. Next slide, please. Okay, so starting now through this presentation, you'll see some timelines highlighted in red. That tells you how long this person has been since they came through our ER originally. So on May 7th, 12 days in, things are no longer working. That's when he was actually intubated. That's that tube I told you about that we stick down their windpipe and we're breathing for him. Next slide, please. That's the current one at day 12. Advanced slide, please. Okay, so this one actually had an earlier tracheostomy. I'll get to that. These people can only be on that breathing tube for so long, and then we have to bump it up even a further notch as far as intervention goes. And what that includes is they go down to surgery, sometimes it's emergent bedside, but they will get a tracheostomy, which is they cut right into their neck. Anybody who's seen an emergent one on ER or something like that, they stick a trach in there, and then they stick that same breathing tube from that ventilator up, and that's how they're breathing. So they're basically skipping this passage right here and starting the input right here. And then a PEG, that's an acronym that's short for putting a tube right into the stomach. So that's skipping the tube that we put down their nose or their mouth to get medicine to their stomach. And it has a line right here, a tube, and that's how we would give medicine or tube feedings to keep them alive via their nutritional needs. The pulmonologists, which pulmonary means lung, they're the ones in the ICU that run the show. They are also known as our intensivists, intensive care unit. They run the ventilator, everything like that, the big drugs. Usually, when someone goes down for a trach, they also get a PEG at the same time. This was kind of in the beginning when we were kind of learning about these patients. So he actually got his on 2 separate dates, if you see in the red. Okay, so the patient returns to the ICU for continued intense care and monitoring. He's critical this whole time. And right after he gets a trach, by the way, I had this patient. This was a patient of mine. It's usually very contraindicated to have a trach right here and then go on your belly, as you can imagine, a fresh surgery. He would not have lived if we didn't do that. These people aren't living if we don't put them on the belly. So right after coming back from fresh surgery, he had to go right back to that, and that also comes back to the importance of skin and protection and checking. Okay, so this slide, many hands holding one patient. This is incredibly important. You guys can probably imagine the tech that's involved with computer systems, machines in a lab, phlebotomists, everyone running that, the imaging from x-ray, the radiologist interpreting it. When they come through the ER and the physician that gets them stabilized and puts the original orders in. The nurses that carry it all out. These people are on death's door. Who's communicating with family? Who's taking care of their spirits and souls? That would be our chaplaincy department. These people, because they're in the same position for, weeks and weeks, they're going to have hits to their joints. They're going to have atrophy, meaning kind of a rotting away of their muscles and not using them. They can't stand anymore. So our physical therapists are extremely important on getting them back up to par. And then our pharmacy, who's making all of these big drips, running them up to that line. They wouldn't stay alive without them. All of these people are extremely vital. Even the people that are not in-house, you have to think of healthcare jobs. People that are far away taking care of the computer system and finding glitches and snags. Insurance, getting the supply to the hospital. national shortages. There are so many people that have a hand in one patient. I kind of listed some of the people off of here. Advanced slide, please. Okay, so 1 week after the trach peg placement, we're on day 34, been here over a month. He is stable enough to transfer to Sioux Falls, has that trach and that peg still in place. The goal after that is to transfer to acute rehab. 72 days later from the initial event, on July 6th, he has to come back to St. Luke's for surgery for a removal of his gallbladder and his appendix. Now those may sound like run-of-the-mill general things that some people have to go through, pretty general. However, we are seeing more and more of these people that actually do make it through COVID, and systemically, it has affected so many things that we highly doubt at that time he probably would have had those two things removed if he hadn't just been through that very, very acute illness. So on July 7th, he spends his 50th birthday in our facility. Advance slide. So you can see slight improvement, but you, if you learn to read slides like this, you can see these COVID patients, even after they get better or after the initial sickness, something we're very worried about going forward in the future is they've got some pretty scarred up lungs. So for example, in healthcare, peak season, if you will, November through February, March, a lot of respiratory illness, your influenza, those people are gonna kind of populate our departments anyway. This year, on top of COVID surge, those people that made it through COVID are going to be so much more susceptible to getting to a critical level, and they'll be re-entering for whole other reasons because of that. Advance slide, please. So, 1 week later, July 17th, he's strong enough to qualify for our inpatient acute rehab. Picture of our gym. 83 days later from his initial presentation, he is transferred from the surgery floor, remember he had his gallbladder and appendix out, to the acute rehab. He receives 3 hours of therapy sessions daily. Now, even in this side of things, it's not just the physical therapist, occupational. Can we speak? Can we put our hands up to our mouth? Can we do everyday things? Can we comb our hair? Can we bathe? You've probably heard of COVID brain. That's very real, not just with our patients, but I had COVID a month ago, and I felt like the biggest ditz on the planet. Just couldn't think of words. Things don't come to you like they should. So imagine being that sick and under for that long. Normal things are not firing like they should. Advance slide, please. Okay. So 1 week, I'll just wait for that slide to pop up.
Taking me to a different website.
There was a final slide about the
Let me see.
All right. So this timeline right here is what I wanted you to see. 3 months of intense medical care. I think it's estimated that over 1,400 different people were involved in this one man's survival, whether it was tech, insurance. 1,400 different people touched that chart, touched that patient. That is astounding and amazing to me that we live in a place where we're willing to put resources into a human life like that. And you can be part of that. So, are you able to go on to the timeline?
Mm-hmm. Can you see it?
Oh. That's just an overview of what we talked about in advance again. It's just the next slide. Yep. All right, so on this slide, there's the 1,400 figure. If you just want to look at that list of people, and this doesn't even touch the surface of all the different kinds of people, just the ones we can think of, tip of your brain, of who has to deal with these people. You know, there are some forgotten ones that I think in our culture we often forget about, but we wouldn't run without them. Housekeeping, for example, the janitors in our schools right now, they are having to go above and beyond to try to protect us and make sure that every surface is clean in between people. Everybody has stepped up and is taking care of this community in this building. There's even your care coordinators, social workers, case workers, they're kind of all the same name award here. They're the ones that facilitate all these things. You know, I had said that he went up to Sioux Falls to this care center and then he had to qualify to come back here for acute care. There's a lot of insurance things that these people have to navigate through in order to get that qualification to get them where they need. And those moves and transfers of appropriate care would not happen without them. These people are all vital. Advance, please. All right, so Alex, I don't know if they're able to open their mic to ask questions or to type them in, but given the flow of what we're doing now, I would like to introduce our panel before they do, because it might be pertinent to a specific individual. So right here, we have Teresa Holst. She works in our radiology department. So these people, obviously, the shortness of breath and the way that COVID affects our respiratory system, every single day, sometimes more than one time a day, for every single one of these patients, whether it be ER, on the medical and surgical floors, the rehab floors, the ICU, big time, these people are getting chest x-rays, and they're the other ones coming into the room when we have that big surge, but even more so now, moving that patient. There's lifting, there's technical knowledge, obviously patient care and how to be kind to people. Because I'm moving in closer to introduction, I'm going to go ahead and put my mask on because I'm not able to socially distance. This is Shelby Lakes. She is one of our providers, a nurse practitioner in our ER department. So she sees these people when they first come in, gets them on that high flow oxygen, makes them go prone, gets them some steroids to beef up their lungs, maybe start some antibiotics if they've already developed pneumonia, get them fluid if they're dehydrated. She gets them to where they can get upstairs and get that next level. So when they walk in on 43%, she's the one that saves them and gets them to the next stage. This is Mark Westrick. He is one of our chaplains. He's actually head of our spiritual care department. He helps not only care for their hearts and souls during these acute phases and facilitate when they're on their way out if they have to pass, when the family's having a hard time, but also things like who gets in the building, visitor-wise. We need to shut down to preserve the community, but there are cases where it's the end and he will kind of go and delve into that and decide who stays or goes. Ashley White is a nurse like myself. She is also the manager of our flex department, which is kind of a med-surg medical floor, and then our rehab. So remember at the end when you got that intense care, she would be overseeing that. This is Mindy Spinner, manager of our PT department. So that intense care again, those muscles, getting those things built back up. Can they comb their hair? Can they shower? Everything that's involved with that. This is Mike Podomac. He is head of our pharmacy department. He is a pharmacist. So all those big, important drugs, seeing if they go together, what's best for the body. Do they have some kind of deficiency with their kidneys to where maybe the dose that works for someone else can't work for that person? He helps govern and oversee and recommend things like that. So I'm going to go ahead and join over here now and open it up for questions.
Perfect. Well, thank you so much. And this would be an opportunity, students, for you to be able to ask questions about anything that you just heard, anything about the case study, as well as maybe specific questions about their specialties or what they went into. I joked in the last session that we had that one of my favorite things is to call on students randomly, so I'm not afraid to do that. So be prepared. But yeah, this is a time where you can either unmute yourself or hop into the chat and feel free to ask those questions. I think one of the questions that I would ask just to get the ball rolling and give students a little bit of time to think about it is it frightening as a care provider or someone in this situation to especially be working with those contagious diseases such as COVID-19? I mean, you spoke to your experience, or anyone can answer this question of just dealing with this. I mean, I think when you're dealing with other illnesses and there isn't that high contagion factor, I'm sure, I don't know, I would just imagine there's added stress. Can any of you talk maybe to that you've experienced?
One of the things that I would say is I wouldn't call it fear. I'm very proud of the staff at this hospital. Yes, there's an added level of concern when there's a contagious disease, and everybody took it very seriously. Concerns for proper protection equipment when you're going in to see people. But for myself, even when this first broke out, I had numerous people saying, well, you're not going to go to work, are you? There's sick people there. And it's like, well, yes, I am. That's what we do. And we approached it seriously and met the needs of the people we serve.
It was also really nice to know that you're not going into it alone like everybody here. We all can talk to each other and say, what are you doing to make it through? What kind of things are you doing to protect yourself, to protect the rest of your staff? So you know that you, as a team, we're all going into it together.
I think that one thing that we need to see from a leadership perspective is those higher up people. A lot of times you don't interact with them if you're a floor nurse. During this time, they kicked it into gear just like we did, where they implemented a lot of procedures really quickly to make us feel safe. One of the things that we had that we don't normally have is it's called a PPE coach. So we had these people that would watch you and, hey, let me watch you put on your gear. Are you covered up? So I think that added a level of feeling protected initially, if you will. We had the HR people. They're normally here during daytime hours. There were just several people from several disciplines that kind of chipped in that were here late at night. So it wasn't just one person, it was everybody, which was pretty neat to see.
Yeah, I think that's an important and valuable point. We do have some questions that are coming in to the chat, and so I want to make sure to get those from the students as well. I would remind our panelists just to speak up if at all possible. I know with wearing masks, I just want to make sure that everyone's able to be heard. So one of the first ones was really, what was it like at the start of the pandemic? I know that things have kind of changed. A follow-up to that, a separate student asked, has your outlook changed over the course of the pandemic, if at all? And I think those two questions maybe go well together. So what was it like for you at the start of this pandemic? And then has your outlook changed over the course of this? And so again, just feel free anyone to answer. And then if you would just please try to speak up, we would appreciate it.
So I work in ER and ICU. I see when they come in and I see them when they're very sick. And I think Shelby can attest to this. When it first started here, it was like an eerie quiet. It was a calm before the storm. Our normal people that were coming through the ER stopped. They were staying home because there was a lot of community fear. And then it just hit us, overnight, inundated. You almost didn't have time to be afraid. You were just in go mode like a soldier. I have to do this right now. This is my duty. And then to get through that horrible surge in ICU, which is building back up again, coming back second, third wave, as they say. It's amazing to me, the human spirit and how much we're willing to adjust to, of what a year ago would have seemed crazy, but when you're doing it every day, your tolerance and what you're made of and what you're able to deal with, it just keeps climbing to where it becomes a new norm. And I feel like the way I feel about the pandemic it still is kind of unknown, but very unknown pathogen. So there was eeriness about that. Then there was go mode, can't think of anything else. Then there was a little dip in the summer, but people don't realize healthcare was still catching up and doing all of that. I feel like healthcare workers in general, our view towards it has changed from we're going to deal with this big explosion, and now our view is, okay, we're in this for the long game. This is the new normal, let's adjust.
And I can speak from the radiology perspective. We stopped quite a few of our services, outpatient services. We pushed out to our imaging center, tried to reduce the footprint of patients coming into the hospital. And we reduced our hours that we were working as far as we didn't feel we needed quite as many staff every day. Well, that quickly changed because, as Lacey said, anytime anybody had a tube put in them or a line put in them or they were intubated or they readjusted the endotracheal tube, you take an x-ray of that patient. So we are now changing gears. We have 2 teams of 2 that are there at 6:30 in the morning starting our rounds of portable chest x-rays. And we do an average of maybe 70 portable chest x-rays in a 24-hour period, and that's in the COVID unit. So we kind of changed what we do based on the need, and now we have outpatients coming in, so we are busier probably than we were at the beginning of the surge, because we have all patients back again. But you do it. This is what you signed up for, and you just go to work and you go home at night and you unwind with your family.
And there is a certain pride also, and you're part of making history. And this is big, and everybody here is part of that. Good stories for the grandkids.
Another question that came up from the students was just thinking about, even with all of that PPE, you talked about the concerted effort towards doing that and wearing all of that gear. Were you finding at your hospital that doctors or some of those healthcare providers were actually still getting COVID from on the job from a patient, or were you able to at least stay away from that side of it?
We had a very, very low transmission rate for our providers and nursing staff. Our own staff actually didn't start getting infected until this fall when all those kids went back to school and it was more community exposure. What would you say?
Yeah, I was gonna say, I don't know about ICU, but the ER kind of, I think even just mainly more recently, more people have gotten it. I know some people have, myself included, got it in the spring, later spring. But yeah, I mean, no matter all the things that we do and everybody tries so hard to be so safe, you're still being exposed, and a lot of staff members have gotten it, and thankfully, there has been pretty good success on getting over it. So, but a lot of people have gotten it. I don't know the statistics, but.
I think this is a good call out. My name is Tammy Hartnett, and I'm the Resources Director. I also oversee employee health. We have only had 16 work exposures, and most of those happened in the spring. The PPE has been extremely valuable for our team members to protect themselves. When we are seeing team members test positive, now those are community spread. I in fact say to many of our people in the community that this is probably a safer place to be than when you're out shopping in the community, because our team members do take it very seriously with the PPE and protecting themselves. So our work exposures from an employee standpoint, employee health has been very busy with COVID. It really has only been 16 in these 7 months. So that's pretty amazing. And we really attribute that to our team members taking it very seriously and protecting themselves with PPE.
Yeah, those certainly are impressive figures. I'm glad you've all been able to stay safe with that. Another question that I think I would like the panel to maybe address before we kick it over and maybe Tammy can talk about some opportunities is I would really think it'd be great if the panel could discuss, a lot of you have different specialties or went into different areas. And so the question was posed that did you know right away that you wanted to work in healthcare or go into that field? Did you pursue anything else first? I think we have a lot of first year students on this meeting, and so we just want to talk to them a little bit about maybe what your experience was in choosing a career path and how you got to where you are.
Well, I can speak up. I'm Mike Fidelman, I'm a pharmacist. Also, it's Morningside years back, but I was kind of a science nerd through school, and I ended up that way at Morningside as well. And I was a biology major, a chemistry minor, and I kind of got towards the end, and I thought, well, what am I going to do with this now? And so something in healthcare was good. Ended up in pharmacy school with Creighton, and then came here after that. So I kind of knew science field, kind of a healthcare area, but wasn't exactly sure to start off.
I'm Mindy, I manage the therapy department, and I knew I wanted to do something in healthcare, but didn't know what I wanted to do until kind of my senior year of high school, and then beginning year freshman as a college student. I went to St. Ambrose University in Davenport, Iowa. But I had kind of thought about nursing. I have family that work in nursing, and then also thought about dentistry and orthodontics, and then had a family member who had a stroke and got to kind of work through their rehab progress and knew that rehab was the area that I'd like to go into.
I would have to say I kind of went to chaplaincy as I'd say second, but it's really about a fifth career. I didn't get into this until I was in my mid-50s, and it was a decision. I previously had been a sales rep and called on hospitals and clinics and had run into a number of chaplains. When I wanted to get into ministry, I went back to school for a degree in theology and then pursued chaplaincy. And it's just a calling on a heart to be able to be with people, whether it's the patients or their families, in the midst of critical situations, and being able to be attentive to their needs, listen to their needs. One of the big things during this COVID crisis is when we had to stop having visitors in the hospital.
It was a family member trying to connect from the other side.
When we had
Yep,
to
you're
tell,
good, yep.
when we had to tell families that they could not come in to see their loved ones when they were patients in the hospital, that became very difficult. And I think that's one of the big roles that chaplains provided, is in soothing some of those family relationships.
I actually wanted to go into forestry and conservation. So radiology is as far away from that as you can imagine, but I graduated from high school in 1981, so yes, I'm old. And I had a counselor at school that said, well, maybe you wanna not pursue that, there's no job. But I know somebody that teaches radiology, why don't you go into that? And I said, sure, I'll give it a shot, and here I am this many years later, I've never done anything since. I taught radiology for a number of years, but the clinical side of it is most important to me. So I was always a clinical coordinator, always in clinical, and now I'm the lead tech in our radiology department. So wouldn't have it any other way.
I took a less traditional pathway. I actually didn't become a nurse till just under 5 years ago. I started off, I was in healthcare early, just doing the clinical side of things, insurance and that. And then when I became a mom, I started serving. So I was in the service industry actually for 10 years. And I really, really enjoyed that, and I loved people. And so that just got me thinking, like, how do I transition and how do I do that? And I didn't really know what to do. No one in my family had went to college, so that just to me seemed like a pipe dream. And then when working in the doctor's office, actually all these things came across my desk, and I talked this guy into getting a colonoscopy, even though it was a lot of money. So he ended up coming back with colon cancer. He was able to get the interventions that he needed, and I just thought, I want to help people someday, and I didn't know what that meant. So I kept serving. I was like, man, I want to do something that's busy and fast-paced and that I can use my brain with, and I became a nurse. So then just things kind of progressed from there, and my nurse manager recruited me to do this job now.
Well, after I was done the Oscar speech at 7, I moved on from those dreams. I was one of those people in college that I am very interested in many things. I find happiness in almost anything I do. And so I was a biomedical engineering major, I was an opera major. I got to be towards the time where I should graduate, had a lot of sciences and a lot of language, but I had always taken religious studies courses. I love any kind of world scripture. So I had graduated with a religious studies degree and went on to get my master's in English, taught English for 7 years. Then I had a lot of student loans. And so I thought, gosh, I gotta make some money. Where is there job security? So I went into the field that made no more money than that. But that was my path. I come from a healthcare family. My first jobs were in a hospital. It's kind of in the background always, but I'm happy doing anything.
Excellent. Well, it sounds like a lot of you had a very winding road, but ended up right where you should be. That's for sure. So Tammy, I would kick it to you then. We have about 10 minutes or a little less left of the presentation. Do you want to talk a little bit about opportunities at UnityPoint for maybe some of these students?
But I'm going to have Mary O'Brien. She's our manager of our volunteer, and then I'll take over from there.
Perfect.
Volunteer manager.
Talk loud. Yep.
You have my seat, Mary?
No. So I manage a volunteer services area here, and I actually have a couple of Morningside students on campus volunteering right now. Unfortunately, because of COVID and visitor restrictions, I don't have a lot of opportunities available, but I anticipate after the first of the year that we'll get to open back up. In the past couple of years, I've had great success with volunteers. Actually, Kenny in the video started off his freshman year as a volunteer for me, and he works here now. And it turned out Perfect. So if you're interested, you can go to unitypoint.org under careers and volunteers, and then you apply. It will come into my mailbox. I will get in touch with you. We'll get you all set up, and then once things open up, we'll place you. I've got placements all over the hospital. Again, once it opens up, I will let you know. We have baby cuddling, and that's always the most popular. So thanks so much.
Thank you, Mary. My name is Tammy Hartman. I kind of jumped in there for a minute there. I'm the Director of Human Resources. I serve as the HR Executive for Sioux City as part of UnityPoint-Health. And I wanted to talk about a few opportunities that we have for you potentially for employment. What we certainly would encourage you to go to our website at unitypoint.org/careers, but we also have some specific opportunities that we're opening up. I'm going to take off my mask as well. For our students, for opportunities for you. We have just developed a new position in the organization called Patient Care Extender. It's a position that we are looking for students with some flexibility in hours and opportunities, and we would have you call our Human Resources office. I'm going to send a flyer to Stacy, and she can get that out to you guys. And you can contact Human Resources directly, and we can get you onboarded. The advantage of that is you can sign up for some flexibility in scheduling in 2 to 4 hours. For college students, we certainly understand that is hard to find that flexibility, and we wanted to, as you can imagine, help with our patient care. This is a new role for us, so we would be onboarding you right through our office, and you wouldn't have to apply for this position. It's not posted. With that, we also have the opportunity to do an on-call position for a patient safety companion is what it's called, a sitter. And we can give you more information on both of those positions if you're interested in signing up for those. And we'll send the flyer out and your contact information. Outside of that, we do have job opportunities on our website at unitypoint.org, and you can apply for those. I just want to say, as I've gotten to sit through this presentation, as Human Resources Executive, I am extremely proud to work for this organization. I get to oversee our employee health. I have seen amazing work, not just in the past 7 months, but this past 7 months. So when they talk about the work that you saw, we really came together as a team. I really believe that we did that. It's an amazing opportunity. If you're interested in healthcare, this is an amazing organization. One of the people on our video, Angela, the HR business partner that went to Morningside, she is super. When we were putting together the video, I was like, oh, you've got to do this video. She is so proud to work here, but she's also really proud of the Morningside roots. So in fact, she met her husband there, so we always kind of tease her about that. So I would just encourage you as students to look at, if you're thinking about healthcare, maybe look at those opportunities, even as a student, to kind of explore that, whether that's a volunteer or becoming an employee in one of those capacities. And if you have questions for any of us, you know, Alex, that we're pretty close to time, just let us know. Thank you.
Perfect. Well, I think that's a great opportunity to wrap up. We're getting close to the end of time, and I want to be cognizant of that if students have to get going to a 1 p.m. class or anything like that. I want to thank UnityPoint-Health St. Luke's for this opportunity, for being flexible with us in this virtual world and environment that we are in. I also want to thank our attendees, all of those students that were able to join today, for their great questions, their attention, all things like that, and their patience as we navigate this type of programming. I would also just reiterate what Tammy just said, is if you have any questions, you want to follow up, you want to have a discussion with any of these panelists today, or you want to find any information about how you could go into maybe their career paths, I would urge you to reach out to me, send me an email. I'm happy to make that connection. But really, if you came to this experience just wanting to learn more about healthcare and possible opportunities or where your future career could go, I think this did a great job of highlighting the number of career paths that are available within a hospital system and just where it could really take you. So thank you so much for this opportunity and for your attention, and all the panelists for taking time out of your day. Everyone take care and have a good one. Be safe.